Welcome back, everyone. We haven't seen you in a couple months, and I hope everyone's holiday seasons were restful, joyful, and you all are staying healthy as possible as we battle through this wave and this surge. Hopefully, the end is near, and everyone can hopefully maybe see each other and connect throughout this whole year. That's our goal at City Match, is to hopefully find connection and networking if possible in person. So we appreciate all of you joining us today and logging in for another virtual meeting with us and training session and changing the date. So I will just leave it at that. I'll drop in a couple of housekeeping. We all kind of know the virtual rules these days. So I want to give Dr. Kramer as much time as he needs. And again, just feel free to be engaged and ask questions. Of course, there'll be time for discussion. So thank you, Dr. Kramer, for being here, and I'll hand it over to you.
Great. Thank you so much, Ashley. And I echo Mike's sentiments. It's really great to see everyone again. It's lovely to see familiar faces. I hope you're having a good start to 2022. And also thanks for your flexibility in the change in dates since this was originally planned for a couple weeks ago. So I'm glad you're able to make it today. So what we're going to talk about today is a little bit about spatial epidemiology, GIS, and maternal and child health. And what we did is kind of looked back at your initial questionnaire survey about skills and experience you had prior to coming into the summer last year. And it looks like, not unexpectedly, there's a range of prior experience with GIS, but there's a lot of folks for whom this is pretty new. And so I've only got a little bit of time today. And so I'm going to kind of calibrate this or aim this at a relatively introductory level overview of several topics that I think are helpful as you begin to decide whether thinking more about spatial data, partnering with other people who already have a lot of skill, whether that's something you want to do. As always, I'd love to have conversation with you, hear feedback as we're going along. So feel free to use the chat or to unmute as we go. And I'll also say that I only just a few moments ago sent copies of slides to Ashley, so she hasn't probably sent them out yet, but you will be able to get copies of the slides, or maybe she has sent them out, I'm not sure, but they will be available to you. All right, so with that, okay, Ashley, can you just give me a thumbs up if you can see the presentation, not the presenter mode? Okay, good. And my sound is okay?
Sounds good.
Okay, that's great. Thank you. I'm just going to do a couple quick things, which is to open up the chat so I can see it. Okay, so mapping MCH. I want to talk about not just like the technical stuff about GIS, but actually trying to think spatially and how that helps us for epidemiology. So I kind of have divided this into 6 sections that we're going to talk about today. A little overview, setting the stage, thinking a little bit about the data issues if we're going to do spatial epidemiology, a pretty superficial introduction to the idea of visualizing or mapping epidemiologic data, so epidemiologic cartography. As I said, something about spatial thinking. So what does space mean when it comes to health data? And then I've just got a small set of applications of cartography or spatial analysis that are specific to MCH, just to kind of illustrate the variety of ways that people incorporate GIS or spatial analysis. And then just a few resources for moving forward. So that's the plan. It's kind of a lot, isn't it? We're going to move right along then. So setting the stage. So look at this. Anybody have any ideas what you're looking at here? This is obviously a map, and it's obviously the United States. I pulled this from a New York Times interactive that they created a few years ago. I'll just give you a second to look at it. Oh, somebody saying something? Sorry. I thought I heard something. Any ideas in the chat or on mute what is being mapped here? Population centers, okay. Certainly does look like it's telling us something about populations.
Population density.
Say that again?
Population density.
Population density, okay. Light pollution, excellent. All right, I'm going to zoom in on a few different places on the map. This is zoomed into the zip code where Emory University is, which is where I am right now. And what that map on the previous slide was and what this map is simply black and white representing every single building in the whole United States. They use satellite imagery to identify every single human-built structure, and they colored it black, and everything else is colored white. So it is simply a visual representation of where humans have altered the surface of the earth, right? Where we've built something. And you can see these intricate patterns of streets when we zoom in, for example, to the neighborhoods around Emory University. This is not quite as zoomed in. This is sort of a mid-level zoom. This is all of the buildings in a section of Pennsylvania in the Appalachian region. And here what we're seeing is sort of the interaction between human building and geology, right? This shape in these lines is representing the way that people's ability to put up buildings, houses, is constrained by the geology, by where there are cliffs and mountains. Or the idea that our meta-human idea of how the world should be is represented in the structures and design. So this is Washington, D.C., and represents kind of the master plan of what a city should look like. I thought I had one other of a city. So my point in this is when we think about why are we incorporating spatial methods or geographic methods with health, some people think about it like environment or temperature or latitude, but I think that maps tell us everything or tell us so much about people, because what we see when we're mapping things are things that people do. So we're representing visually something about social human organization. And to the extent that we think social human organization drives health, I'm thinking social determinants of health or patterns of age, et cetera. The social or human interactions drive health outcomes. We can use maps as one tool or one lens to see those. So shifting a little bit more to a health outcome. Another parallel we can draw between maps and data is with our use of summarization. So what I'm summarizing here is the infant mortality rate in 2013. I'm summarizing it in a tabular form on the right, so it's a table, and I'm summarizing it as a map on the left. Obviously, the map is kind of boring, right? Because there's just the one value for the US. Alternatively, I could break down the US into the states, right? So this is often what we do in a tabular form too. Say, what is the infant mortality rate separately by state? And in this case, the table on the right, I've just sorted it with the highest rate states at the top, lowest rate states at the bottom. Obviously, the table goes below this slide. There's more rows than that, but you get the idea. Now, if I were to take the idea in that table and translate it into a map, we'd get what we have on the left, where basically I take every state, I color it according to the infant mortality rate, and I sort them from high to low. So it's an accurate representation, but it's not particularly useful. It's not until we put the data at the state level together with the geographic location that we begin to see patterns like this. And so this is an example of how maps help us see something that, for example, you couldn't readily see it in the table. You can't easily look at the table and recognize that there's a cluster of high infant mortality in the South. But it's very easy to see a cluster of high infant mortality in the South when we look at the maps. So maps sometimes bring out patterns and data that would not be apparent if we saw them in a different way. So I'm going to move forward with several axioms of spatial analysis. And this is adapted from something that Dr. Lance Waller often says. He's a spatial statistician. The first axiom is that maps are cool. If you don't think maps are cool, you're probably not going to like much of the rest of this. But I think that you're probably here because you think maps are kind of cool. There's something interesting about them. So I'm just going to say they are cool. And if you don't agree with me, then you can go. Okay, so the other thing I'm going to say is that space is complicated, that the way we represent things on maps isn't just simple. But in order to make it simple, we have to have the third axiom, which is that maps are always filtered reality. They're never everything. They're only parts of things. And that idea is really important. Every map potentially has one truth and a lot of lies. It's possible that it has only lies. That's always an option. But at best, every map has one truth and a lot of lies. In other words, it obscures or blocks out a lot of stuff to pull certain ideas in. So if we are involved in making maps about health, we have to be careful about what is the truth the map is saying and what lies is the map saying. Now, another kind of general concept I wanted to introduce early is that I feel like a lot of people use the word GIS to encompass everything that I'm talking about today. And I would like to separate GIS out as being a separate or distinct piece. GIS is Geographic Information Systems. In other words, it's about software or technology that is used to store, manage, manipulate spatial data. So it's super important, but it's not everything. So cartography is the visual presentation of spatial data. Sometimes GIS software helps us carry out cartography, but the act of visualizing data is a science and an art in and of itself. So it's separate from GIS. Similarly, GIS or cartography do not necessarily mean we're doing any statistical analysis. We could just show the rates that we have or the numbers that we have without estimating or calculating anything. Alternatively, we could carry out statistical analysis that's specific to spatial processes. And then finally, this idea of spatial thinking, which again, what I mean by that is the idea that if we're gonna make public health or epidemiologic sense of spatial data, we need to think about what does place mean? What does it mean from the point of view of population patterns, of prevention, of interventions, of resource allocation? So thinking about how space is part of the story of public health. So I think all of these are interrelated, but I want us to get away from using GIS as the catch-all for all of them. Okay, so that's just some big picture things, like why would we do this? This idea of social processes, human social processes being represented in maps, and the notion that when we're talking about spatial or GIS, that it's actually a lot of interlocking parts. Okay, so what I'm going to do now is shift on to a little overview of data, because that's often the things that motivate, animate, restrict what we can do as epidemiologists. We're thinking about what are the measures that we have, what are the data we have, how can we represent them? So let's talk about data. If you're doing at the most basic level, just simple mapping or something more complex that's statistical analysis, epidemiologic analysis of spatial data, you need the data to begin with. And I would say there's three sort of big buckets of kinds of data that we often use when we're doing spatial projects in epidemiology. The first one is health outcome data. That seems relatively obvious, but we need to have some measure of individual or population aggregates of the health outcome of interest. The second one is actually optional. We could just map, like I did with infant mortality, the health outcome without having a predictor. But a lot of times we do have also exposures or predictors or covariates. So that's a second kind of data. It's not required. We could do just only the first and third here. But if you had a story, a question that involved an exposure and an outcome, then you obviously need the exposure measured. And that could be measured individually, or it could be like a contextual environmental measure. And then the third thing, and this is new, the first two, of course, are obvious. That's what we've needed for all kinds of epidemiologic analyses. The third thing is new, and that's geographic feature data. So I'm going to talk through each of these three and like, where do we get these data? Another challenge with having these three different data sources, a challenge that is actually present in other kinds of analyses, but becomes particularly specifically acute in spatial analysis, is that we need the outcome data, the covariate data if it exists, and the boundary data. We need them to match up some way. In other words, if you wanted to say, what is the infant mortality rate at the zip code level, that only works if you've got infant mortality counted up at the zip code level, and you've also got geographic boundaries at the zip code level, right? So we need to align the geographic extent and the spatial resolution. We need to think about, is our question something about neighborhoods, something about counties, something about states? Like, what is our question that we're trying to answer, and do our data match that? Okay, so health outcome data. This can be arranged in different ways. One is we have prevalences, risks, rates, where it's a numerator and a denominator. We've counted up people. So infant mortality, we've counted up the number of live births and then the number of infants who died in the first year of life. So a numerator and denominator, we've got counts. That gives us the most flexibility because we both understand the prevalence, risk, or rate, because we can take the ratio of them, but we also know things like this is a high rate, but actually there were only 10 births and 1 death. So it's high because there was just a small count. So having numerators and denominators is nice because it lets us understand variation in population size. But sometimes we only have prevalence, rates, or risks already calculated. In other words, we don't know the numerator and denominator, but we know the ratio of the two. So health outcomes data could come in either form, counts or already calculated values. And then we get them from lots of sources. The common places that we use are things like vital records. So birth data, death data, fetal deaths, maternal deaths, pregnancy terminations. But we also have surveillance systems. And depending on what you're doing in your state, you may or may not be able to connect these surveillance systems to small area indicators like zip code or census tract. So like PRAMS, if you link it to the birth certificate, you very well may be able to connect your PRAMS data to census tracts. Now, of course, PRAMS was not designed to be representative at the census tract level, but you could be able to at least do some exploratory work understanding how many PRAMS cases came from different places. Similarly, vaccination data or reportable infections or birth defects or cancer are other surveillance systems that often have geography. When I say geography, I mean like some way to connect it to a county, a zip code, a census tract, an address, that sort of thing. And then another kind of bucket of data are things like hospital discharge, Medicaid records, WIC intake records, Title X reporting. All of these things have been used at points in time. Here are just a few links to specific places you can get national data. So cancer incidence data, you can go to CDC, NCHS, you can use CDC Wonder. You can get BRFSS data that's been modeled or manipulated to sort of be extrapolated to the census tract levels. This link is kind of interesting, and it provides estimates for some of the BRFSS indicators at small areas. Okay, so that's outcomes, right? We know we need that. So recall the exposure predictor covariate, you might not need this if you're just want a map of, the proportion of women who had no or inadequate prenatal care in your state. That's all you need. But if you wanted to analyze whether that is related to the number of OBs per capita or the location of public health clinics, think of that as now an exposure outcome or two covariates that you want to connect together. So now when we think about this, we can think about these exposures as being individual level, like are you measuring something about the individual people, or are you measuring something about the context? So the context might be like, how far is the nearest clinic? Or is there a clinic in your county, for example? When we think about exposures or predictors or covariate data, they can come in many ways. I'm going to talk about the geographic types of data, but they could be points, like you could measure how far the closest grocery store or clinic is from someone's home. Or they could be like buffers. That's like saying, do you have a grocery store within a 5-mile drive of your home? Or they could be like, a fixed definition of a unit, like, is it inside your zip code or no, or inside your census tract or no? Or these things could be measured in some sort of a more dynamic way. So people are thinking about activity space, like, where we sleep at night is our residence, but where we move through the course of the day, maybe the kinds of things we're exposed to. And so maybe we don't want to only measure where you sleep at night, but also where you go during the day. And then at the bottom here, I just have this list of kinds of things that we often see used in spatial analysis as exposures, predictors, or covariates. Things that quantify the socioeconomic context, or maybe the built environment, like housing quality or walkability. Or really importantly, the healthcare environment, like proximity to care, or maybe the density of care, even something about quality of care. And then, of course, things like the toxicant environment, like air pollution or water pollution, that sort of thing. Right? So these are a lot of kinds of data that could be spatial. Where do you get them? Well, it kind of depends, but here's just a handful of places that I think have a lot of kinds of data that we might want to use. The census, American Community Survey is one. So lots of small area estimates of, for example, how many women of reproductive age are uninsured. You can get that from the Census Bureau, and you could map that at a small area. Using Policy Map or the Robert Wood Johnson Foundation County Health Rankings. These are two organizations that have aggregated a lot of kinds of data that are really useful for thinking about social and contextual drivers of health. So you can download all kinds of data from them. And then the Area Health Resource File is developed by HRSA, and this has, you may use this already if you're thinking about health provider shortage areas in your state, but it's got information on, for example, how many certified nurse midwives are there, how many OBs are there, how many beds are there in each county. So it's a place that gives geographic information down to the county level, but also counts of particular health resources. All right, so we talked about one kind of data was the outcome data. Where can we get that? Another kind of data is covariate or exposure data. Now, the third one, I said, this is the thing that's most unfamiliar to the conventional epidemiologic approach. Everything I just talked about, you might already be engaging with if you're just doing conventional non-spatial epidemiology. But if you want to do something on a map, or you want to do something about a spatial analysis, you got to deal with spatial data. So before I talk about the particulars of spatial data, the particular sources, I want to just, as a very high level overview, give you a couple of definitions of words that you may hear, because it's maybe useful to know that these kinds of data exist. Spatial data basically exists in two sort of data models. What that means is data is either vector data or raster data. So vector data is probably the most conventional thing that we use in public health or in epidemiology. And it's represented as either points, lines, or polygons. And it's a compact way to store data, and it has a lot of useful information, including things like being able to draw polygons around your county or your census tract, but also can be used to identify lines that are, for example, transit lines or roads, or points, buildings. In contrast, raster data, instead of having this kind of more compact geometric idea, raster data is like a digital photograph where every square unit, and how much is a square unit depends on the resolution, but say every 500 square meters, it is one cell in the digital picture, one pixel in the digital picture, if you will. And we use color of the cell to represent something about the underlying statistic, like, for example, the density of the population. So raster data is another way data exists. So you can think of if you were to get data from the internet, or somebody were to send you something, spatial data exists in its vector mode or possibly as raster data. So what are the kinds of data we can get, and where might we get them? So there's a lot of publicly available data. And in fact, the number of sources of publicly available vector data in particular has just blown up in recent years, which is great. It's because lots of people are doing mapping now. You know, you see all kinds of kind of apps and interactive things online where you can like see a map of the US and then click on something and it zooms in there, and it, you know, you get all the subparts within the state and you can click on it and zoom in again. So there's lots of data that's out there, and as more people are using it, it becomes more available. So publicly available data, things like census boundaries. You can just download all of the boundaries for counties or for places, which is kind of like cities, or for census tracts or for block groups. We might also be interested in like administrative or political boundaries. So you might have perinatal regions in your state, or you might have public health districts in your state, or maybe school districts. So you might be interested in, for example, talking about the severe maternal morbidity rate by perinatal region to understand whether there's something that's going on, you know, differently across perinatal regions or across public health districts. In addition to the publicly available data, a lot of times people do have various kinds of custom created data. So people are, you know, using their GPS and their phone to create kind of unique paths or unique data points all the time. So you might have GPS points, or you might even be partnered with somebody who's made some kind of a modeled surface. So Like here in Atlanta, Georgia Tech has done a lot with air pollution modeling. So they produce these maps that are sort of like continuous topographic maps of the air pollution over space. And they do that by interpolating between measurements that they have from different sensors around town. So there could be custom created data. And these things can be also network features. That means like lines that are connected together, like roads and transit, or they could be like service catchment areas. So lots of kinds of geographic data. I'll tell you the most common thing we use for most sort of applications are these census boundaries or political boundaries to make what's called a choropleth map, where we have the polygon that represents the place, like county or public health district, and we color the inside of that polygon to represent some kind of an epidemiologically interesting statistic. So that's probably the most common application. And here are some places where you can get the data. As I said, the Census Bureau produces and updates all of the polygons for all of the kinds of census units there are. OpenStreetMap is a really cool sort of crowdsourced place where you can get lots of information, including like the number of pubs or hookah bars or things like that. You can get lots of specific kinds of things, businesses that might be populated in OpenStreetMap. And then some other that has sort of weather data, global earth science data, etc. Okay, so I've just gone through a lot fast. So we talked about the overview and we talked about data. I'm just going to pause and take a breath. And I'm also going to pause and see if anybody has any questions, clarifications, comments about what we've talked about so far, because I know I'm just flying right along. All right. You've either just walked away from your computer and you're getting a Coke and you're going to come back later, or everything is crystal clear. Excellent. Okay, I'm going to move on then. Again, we only got like an hour, a little bit over an hour. I teach like a semester-long course where we have like 45 hours of contact time, and we have lots of projects and activities. Like we're kind of cramming a lot into a small amount of time. What I'm going to talk about now is a few things about epidemiologic cartography that I think are useful if you're in a beginning stage, in an introductory stage, and you're maybe sitting down with a GIS analyst in your health department, and you're talking with that person about a project you would like to use spatial data for, and you would like to have some familiarity with the language and some of the issues that come up. So the goal isn't necessarily for you to know how to do everything at the end of an hour, because that would be impossible, but more for you to have a sense of the range of things that you might that might come up in conversation as you collaborate with somebody who does have a lot of experience with the software and with the data. So definitely an introduction to epidemiologic cartography. So first of all, this map always cracks me up. When cartography doesn't quite work right, when it goes wrong. So this is from 1948 World Geography. It's mapping the density of hog production in the United States. So the legend says that each dot represents 5,000 hogs. Does anybody see any problem with this? Any problem with this? Or anything confusing? So here are some things that people who tweeted about this had to say. Because the dots representing hogs are visually the exact same color as all of the other ink on the space, it's as if there's untapped infinite hog supply in the ocean, or each state is lined with an impenetrable wall of swine. We are trapped, or we've already lost Canada and Mexico to the hogs. But interestingly, the Great Lakes seem to be completely hog-free. So this is silly, but it's also a reminder that when we visualize data, we're asking a lot of a picture. We're putting a lot of work into that picture, and we need to be careful that it's really clear to the reader, to the viewer, what that work represents. What we would like is something that takes very little effort for the reader to quickly grasp a complicated idea. But if we do something, for example, like take the thing that symbolizes what we're looking at, hogs, and the boundaries of counties, and we symbolize them in the same color, then we may cause confusion. So that's what we want to avoid. We want to think about how to make clear, simple, easily digestible visualizations. Why would we do this? Well, really, as I kind of alluded to in the beginning, the power of spatial analysis and epidemiology is that space tells stories. It tells stories about how humans organize themselves. It tells stories about where things are and how they interact with one another. So in public health, we could think of epidemiologic cartography, by which I just mean making maps of epidata, for surveillance, like mapping health outcomes, for hypothesis generation, like maybe putting the health outcome and some exposures next to each other and looking at patterns to say, it's really weird. It looks like there's this, excess infant mortality rate in this part of the state. I wonder if that's related to X or Y. Or thinking about resource allocation, right? So maybe if you were planning something like a perinatal regionalization approach and you wanted to know something about what should be catchment areas, or what's the drive time between counties or between places in your state and the highest level perinatal care, and you wanted to figure out how to optimize that, you might use something like cartography. So this idea of space as a storyteller that can achieve epidemiologic goals for us is useful. So there could be some simple steps that we might define to be able to produce a good map. And just like a good research question, just like a good statistical analysis, it needs to start with clarity in your mind about the purpose, the question, or objective. If we just start jumping into ArcGIS and making maps of stuff willy-nilly, we're going to end up with a lot of garbage and not really clear whether we achieved a goal because we didn't have a goal, right? So we want to have a goal, like what is the thing you want to know? If you're clear about that, it's going to be much easier to get an answer. We want to think about our audience and output. We need to collect and prepare data, as we talked about, and then we need to symbolize that data. In other words, make it into a picture. So I'm going to talk about a few of those things now. So what is your question or objective? Now, I would say there's, as I alluded to in the space as a storyteller idea, there's lots of kinds of questions we can ask. We might be doing something really exploratory, like do the attributes of cases or exposures or population at risk, are they basically the same everywhere in the state? Or are there places in the state where there's an exposure that's really high or a population at risk that's really low or something like that? So we might be kind of exploring data. Or health service planning, we might be trying to estimate something about supply and demand. And is our supply of health services, maybe COVID testing, for example, in line with the demand where people are who need COVID testing? And then epidemiologic analysis, like actually asking questions about the distribution and determinants of health in populations. Like, does proximity to an exposure affect the risk of disease, or are there spatial clusters? So there's lots of kinds of questions. Now, the audience thing is super important when you're making a map. And that's for a few reasons. One is the more public your map is going to be, the more care you need to take about all of the sort of assumptions and hidden assumptions that are baked into it, and make sure that you're not unintentionally misleading people. But also there could be different levels of sophistication depending on who your audience is. So the most frequent audience when I make maps is me. I use maps all the time just as data exploration. I get a data set. If it's geographically referenced, I will make a map of it because it just helps me understand something about the data. So the map is only for me. It's part of my understanding, just like you might do, a proc univariate in SAS, or you might do some other kind of descriptive process. So the first audience might be you, and obviously the kinds of maps I make for me are different from the kinds of maps I make for the public. Or maybe they're internally important. So you're using it to, share with your team in your department, for example. Or externally important, but still talking to epidemiologists. So you go to CSTE and you're presenting something. Or probably what's frequently the case, you actually are making a map to share publicly to legislators, the media, or the public. And there you really have to take a lot of care about the representation of the data, the choice of color, the title of the map, etc. So here's just a few things to think about as we think about what's important on a map. So this kind of map, I think I said a moment ago, is called a choropleth map. Choropleth simply means that the map is made up of polygons, in this case it's counties, and we use color to represent the value of a statistical parameter. So what the parameter is important. So in this case, this is county level estimates of obesity. You can see based on the legend that the colors go from kind of a light color to a dark color with different, I guess this is actually BMI. Is it BMI or it might be percents? Oh, it says percent right there. Sorry, my mistake. So it's prevalences. So this kind of map is a common descriptive map where we have an incidence rate or a cumulative incidence or prevalence. We've got an aggregate value that at some point in time had a numerator and denominator. Maybe we actually have those in our data set, or maybe somebody calculated the prevalence for us and we don't have the numerator denominator. So what's important here is thinking about the unit of aggregation. What are these units we're showing? In this case, as I said, it's counties, but we could have also had smaller units like census tracts or bigger units like states. All right, so this is a slightly different kind of visualization where the parameter we're looking at is not just the health outcome, but actually the location of health services. So this is a map. The choropleth colors of the counties are stroke mortality. So age-adjusted stroke death rates per 100,000. But really what they're showing here are the little tiny blue H's, which are certified stroke centers. And one of the things you see is that almost all of the dark purple places, which is the places with the various highest stroke mortality, are more than 30 minutes away from a certified stroke center. And 30 minutes is sort of that critical window when you want to get to care. So this is effectively demonstrating the spatial mismatch of the location of services, which is the stroke centers, and the highest need, which is the places with high stroke rates. So the parameter here is maybe about the geographically referenced exposure. Another kind of parameter is actually a correlation or an association. So for example, a beta coefficient from a model, or a standardized morbidity ratio, or a risk ratio or odds ratio. Although it may sound counterintuitive, you actually can do models where you allow, for example, the odds ratio or the beta coefficient to vary over space. You're sort of asking, is the relationship between X and Y stronger in some places than others? In this particular example I have here, this is looking at using a method called geographically weighted regression. And what is being shown here is the spatially varying association between the percent of women uninsured and the percent who had late or no prenatal care. And what you can see is these are beta coefficients. There are places where essentially the correlation is null. There's some places where the percent uninsured is uncorrelated with late or no prenatal care, but there are other places, so for example, up here in southern Michigan, northern Ohio, and Indiana, where the correlation is strong and positive. So this idea, like, does a relationship vary in space, can be interesting. Now, the point that I'm making here about cartography is when we have something that perhaps varies in a way that isn't just like low to high, but actually varies around, for example, a null value, like a relationship of 0, we need to use different colors. We need to use something called a divergent color ramp. So when we're thinking about how to visualize this, the kind of parameter we're mapping is really important. If it's an SMR or a risk ratio or an odds ratio, and it goes both below and above the null, then colors need to make that apparent. A few other things about communicating epidemiologic data with maps. Titles do a lot of work. Clear, accurate titles that tell what, who, when, where are important. Clear and accurate data sourcing. There should be a footnote or a legend that is really clear about where the data came from. Data scales and units. So if it's not obvious, like if it's a map of the US, we probably all know which way north is, or roughly the scale. But if it's a map of the city of Atlanta, and many of you don't know anything about the city of Atlanta, it's useful to put on a north arrow and to say, 1 inch equals 5 miles or something like that. And then symbolization, the choice of color, the size of symbols, that those fairly represent the actual data distribution that we're interested in. So a couple things just about color. This is from a website called colorbrewer.org, and it's actually created by Carol Brewer, so it's a nice use of her name to brew colors together. And what she has done is she has developed a set of color palettes, and actually ArcGIS and R and many other GISs have these same Color Brewer palettes kind of baked in because they become relatively standard. What they do is they give you an opportunity to look at different color sequences that are sequential. In other words, low to high in sort of a color ramp that goes from light to dark, or diverging, like maybe there's a light color in the middle and then a darkening blue in one way and a darkening red in the other, or qualitative, like if you wanted to talk about something like states that did versus did not have Medicaid expansion, right? It's not a continuous thing, it's yes, they did or no, they didn't. So that would be qualitative data. So thinking about the choice of color and how color communicates what you want is really important. You can also think about things like color blindness, or whether you're gonna show this map on the website or a projector, or you're gonna print it out, that sort of thing. Now, a really important issue, and one that can be tricky, is when you have the data. If we think of the data like low birth weight prevalence as being continuous, but we want our map to be colored so that we highlight certain epidemiologically important patterns, we have to figure out how to slice and dice the data so that colors represent something epidemiologically important. And most GIS software have many ways for making these breaks or these cut points in the data. What I'm showing here are 4 versions of the exact same data, and all that's different is I used a different setting for how to break up the data. So if you look at these, I would guess that you, as I, would come away with very different conclusions about the distribution of the outcome, depending on which map you looked at. Okay, see, there's a question here. Are there recommendations to use or not use particular color combinations, keeping in mind that people are colorblind in other situations? Yeah, so the colorbrewer.org site, there's actually a little radio button. I think maybe you can see it right here. If you click colorblind safe, it will only show you the ones that are visible for people who are colorblind. You can also click printer friendly or photocopy safe. There definitely are colors that have all kinds of emotional responses. People actually do a lot of work on the kind of cognitive response that humans have to color. So like loud, angry colors, red, can really be an alarming color. And so sometimes you can use that to good purpose, but sometimes it can be exaggerated. Some of these colors also may diminish the story by making everything look a little calmer than it once. You kind of want to find something that's not too hyperbolic in its communication, but is effective. Great question, thanks. Okay, so we've got these 4 options here. So which should we use? Well, first I'm going to say there's no single, like, always do this, but I'm going to tell you my opinion on them. And it is partly backed up by some cognitive research using epidemiologic data. So this first one in the upper left is called quantile breaks. That means, what if we take all the counties and we divide them into 5 bins with an equal number of counties in each bin? So it highlights basically the rank order. It tells us something about the dark blue are the 20% of counties with the highest rates. The light are the 20% of counties with the lowest rates. Now, what we know about quantile breaks is they're arbitrary, right? They're driven by the data. So it feels like it's not a very robust way to go. Other options are to use standard deviations. So to find the mean rate and then to say which counties are more than 1 or 2 standard deviations from the mean. You can see that when we do that with these data, it is useful for detecting outliers, but in this case, there's only 1 extreme outlier. So if all you wanted to know is where's the biggest outlier, it would tell you that, but it doesn't tell you much about the variation within the state. The default in ArcGIS is this thing called Jenks natural breaks. It makes sense for some kinds of data. In my experience, it almost never makes sense for health data. I can talk more about that if anybody has questions, but I would, even though it's the default thing that ArcGIS wants you to use, I would say never use it. And then there's this thing called equal intervals, which says, let's take the difference between the maximum value observed in the data and the minimum, and let's just break it up into nice, pretty chunks, like in 10s or 20s. What happens is the maximum, if the maximum is an outlier, it again may have lots of color zones like 46 to 69 where there's hardly any actual people there. So the one that I have as what I think is the best starting point is quantiles. And here's the reason. Even though quantiles we know are arbitrary, what has been done is a number of studies where people, where cartographers presented the same data represented in a number of ways, including these ways here, to epidemiologists and to non-epidemiologists, and asked them to interpret patterns in the data. And although the cartographers have always been the first to argue against quantiles because they don't like the arbitrariness, they were surprised to find that the most consistently accurate interpretation of the data came from when the data were represented using quantiles. So that's my argument for it, is that I feel like even though there are problems with quantiles, they do help us identify patterns by dividing up data that way. Okay, I see another question. Can I speak more to that? Just use it for, okay, so I'm not sure, the natural jinx. Okay, so the natural jinx, yes, I'll speak more to that. The idea with natural jinx is cool. So what it's supposed to be is, imagine that continuously distributed data aren't just normal, but maybe they're like bimodal or trimodal, so that there is some natural differentiation. Like there's counties with super high rates, and then there's this separate chunk of counties with really middle rates and a separate chunk with low rates. And that in between those chunks, there's really obvious gaps. That's what natural jinx is good for. It's good for finding natural breaks in data so that you take, you basically keep those truly high rate counties all as one color and the middle ones as all as one. So the idea is good. In practice, data that are more normally distributed, which is most of the data that we have in, for example, distributions of disease rates, they often aren't bimodal or trimodal. They're often kind of skewed and normally distributed. Then the algorithm that's making those natural breaks, there's actually nothing natural about it. It's just picking something. It's using some algorithm, but the algorithm isn't actually very meaningful because there isn't actually a natural break. And so what that means is it feels even more arbitrary than quantiles. At least quantiles, even though they're not perfect, at least I understand what they are. A fifth of the counties are in the high, a fifth of the counties are in the low, a fifth of the counties are in each group, right? So at least I know what the problem is. Natural jinx, I have no idea, right? You might notice that I've included here the histogram. So the histogram shape is the same in all because these are all the same data. But what you're seeing is where the colors change. And so, for example, you can see that this does seem like a natural break between, can you see my mouse? I'm hoping you can see my mouse. I'm looking at the natural jinx at the bottom left, and that the light yellow color, there's a bunch of lows and then there's this spike up. So that actually does seem like a natural break. But some of these others don't necessarily, like this one here, I don't think it's necessarily real. It's just about, the count of counties. I don't think there's really a spike there. So that's my argument against it. In theory, it's a good idea. And if you had data that did have natural breaks, that would be sensible. If you have something that looks more bell curvy normal, I don't think it's sensible. What's always a good idea is, when you're making maps, it's usually easy to switch between these. So try the different versions and get a sense for like, how different would the story be if I chose this than that? And think about, well, why would I choose this one or that one? Okay, sorry, that's maybe more than I meant to spend on that one, but I get all kind of excited about cut points, as you can imagine. Okay, so as I said, at best, a map tells a single truth and many lies. That's at best. We would like at least one truth to be there. When I say many lies, what I mean is the only way a map is useful and interesting is by obscuring all kinds of stuff. Like we don't want, census tract boundaries on a national map because that's way too busy. We probably don't want the highway system in every possible road if we're looking at, rates of infant mortality on a national map. So we need to figure out what are the key things that are important to this map, to this story. So we're going to block out a lot of stuff. We're going to pretend like it doesn't exist in order to emphasize or filter something else. So what's the main message? How is our data validly and fairly represented? And does the map tell a clear story well? That's what we would like. That's actually pretty challenging. All right, let me see how I'm doing for time. All right, I think we're doing okay. We're going to go a little bit over an hour, but I don't think we're going to go to an hour and a half unless we have some more conversation. So fourth, spatial thinking. All right, so we've talked about issues with spatial data. We talked about kind of making these maps. But what if we want to do a little bit more? What if we want to kind of interpret, make sense of, hypothesize, think about what all of this means? Spatial thinking, what does it mean for MCH? The most classic sort of spatial map of public health or epidemiologic data is John Snow's map of cholera. So let's just think a little bit about the things that pretty simple map did. So that map that John Snow made, one thing it did is it put cases in context. So it lets you see the proximity of cases. Recall that the little dark lines are deaths from cholera. It lets you see the proximity of cases in particular in relation to a point source, in this case, the Broad Street pump. So proximity to the pump. It's not always that the positive expected correlation is useful. Sometimes the unexpected pattern is really useful. So outliers were important here. So for example, one of the things that became apparent from the map was that there were fewer cases of cholera at the brewery because two things, they had a separate water supply, and apparently they also gave everybody free beer to drink. And so instead of drinking water, they were drinking beer. So they were less likely to get cholera. Then there was also a case of a woman who had cholera who was not anywhere near the Broad Street pump. That led to additional investigation, and it turned out she particularly liked the water at the Broad Street pump, and so she had somebody deliver it to her. So the outliers, both the things that are no cases but near the point source, and the things that are cases but far from the point source, helped contextualize what was happening. And they become apparent when you see them on the map. But not only does it put cases in context, in the case of the John Snow map, it questioned a causal paradigm. It gave a different way of thinking about things. Remember, miasma theory was the thing that everybody thought was the explanation at the time of cholera. And so now somehow John Snow is saying, well, no, I think it's about this water. Like, it's not just about the general miasma in the air, it's actually about the water. And then it had implications for action, at least to the extent that we can believe it, exactly who took the pump handle off or disabled the pump or whatever, and at what point in time. It's a little debated, but the idea that the translation of the information from the map to a kind of action is important. So I think this nicely kind of encapsulates some of the ways that we can think spatially about epidemiologic data, put cases in context, question causal paradigms, and think about implications for action. So I'm going to show you some slides that are adapted from a lecture Ana Diaz-Rue gave at GeoMed a few years ago. And she was kind of telling a broad story of spatial thinking in epidemiology and how it sort of has evolved. So her argument was that when we first started thinking about place and health, we were really thinking of it as a context. Things like, the difference between being in a rural versus a city place, that was important somehow. So it's almost like we were treating place as just the container for health. It was a useful sort of category, but otherwise we weren't saying much about what the place was. And then that evolved. We started thinking more, well, maybe places actually cause health. Maybe there's something about where we live or where we go, like air pollution or access to fast food or healthy food, that shapes our health. So the features or the attributes of the places are causal exposures. And we can think of the attributes of places as counterfactuals. We could say, well, here's your health because you lived here, but what would your health have been if, counter to fact, you lived in a place that had a different exposure? So we can begin actually thinking causally. So it gave us tools to conceive of exposures, to measure exposures, to begin to explain variation. Well, then we started thinking, not everybody seems to be affected in the same way by place. Maybe there's an interaction or effect modification so that attributes of place are really important for some people, but not for others. Imagine the idea of food deserts. If you have a car and you have enough money for gas, living in a food desert really might not be a big deal. You can drive to a place where you can buy groceries. But if you don't have a car or you don't have money for gas, maybe you can't. And so you can only shop at the convenience store. So that's in a situation where there's a contextual piece, food environment, but there's also this individual piece that is modified by that, and that's whether you have transportation. So this is a slightly more sophisticated idea of the causation, that maybe each of us navigates our spaces in ways that are slightly different because we aren't just empty recipients of our environment, but we actually have agency and attributes of our own, and so we are interacting with our environment. And then what Diaz-Roux argued was we're now at a place where we're thinking of place as a component in a complex system. And this is, I think, it's exciting and it's also challenging because complex system modeling is a challenging thing. But the idea that places, it's not just an interaction between cars and food environments, but that we have all sorts of patterns of interactions that together have emergent properties like the development of obesity prevalence in one place versus another. That's a combination of cultural and behavioral and social and environmental health service things. So that idea is very intriguing. It's also harder to operationalize, but that's sort of an arc of where spatial thinking in epidemiology has gone from space as just a container to place as part of this complex ecosystem. So I think it helps us think about, well, what does it mean when we make a map of something? Why is it that way? Is it just because all the sick people decided to go to that place? Or is there something about the place? Or if all the sick people decided to go there, why was that? Is that because that's the only place that's got affordable housing? You know, what are the processes that produce what we're seeing in a map? All right, so now I want to give just a couple of applied examples. They're actually not very in-depth, but just examples of things from the literature of how people have used spatial work in MCH-EPI. So this is actually, I think Ashley Haraya is on. I can't remember. I think Ashley, did Ashley give a talk last summer? I know Ashley is the HRSA lead for the summer workshop this year, but I think she was, did everybody meet Ashley last year?
Yes,
No.
for analytic performance measures.
Yes, exactly. So you all met Ashley Haraya. So
So
Ashley does.
you're featuring this. Thank you.
Yeah, Ashley does all kinds of cool spatial stuff. And this is just one example. And this is a great example of I think a very useful kind of use of spatial epidemiology, which is sort of describing epidemiologic patterns. So descriptive spatial epidemiology of neonatal abstinence syndrome. So you can see a number of different things represented here at the state level, NAS per 1,000 birth hospitalizations, the percent change in NAS over time, maternal opioid related diagnoses, and percent change in maternal opioid diagnoses. So this idea that we can use maps to summarize data that we might just put in tables, but we can get a new picture of the data or of patterns by seeing it in a map. So you could do this in your states with counties or in your states with census tracts, depending on what the data was. Okay, so this is one example.
Just one extra thought on that.
Yeah, please do.
If you have it up. I do have some tips I could share on the continuous choropleth. So I think we talked about this, that if you just look at that figure A, if we tried to bin that into quartiles, you would miss the extreme variation in the data. It would really mask, how stark those differences are. You would just have 4 colors, and a state would be in one of those bins. And so this was a request actually from, I think, a JAMA pediatrics editor that in a different paper for developmental screening requested the continuous choropleth. And ever since then, I've never gone back to any kind of binning because I feel like it artificially reduces the detail in your data. So again, I can try to put that in the resource list. I had a GIS pal help me in figuring out how to show that defined interval, basically to make it a really small interval, and then can show that full spectrum of variation. So sorry, just adding that.
No, I love that. That's great. And I'm going to give some friendly pushback to that too, because I totally agree. And here's my pushback. Every map tells a story, and often there are many stories in data. So the story of an outlier is one kind of story, but what you see here is West Virginia, right? What we don't know is the variation among the other states. So every map tells a different story. And so we could get complementary information from different kinds of maps. And I think a lot of times that can be useful. If the goal is to find the outlier, then definitely something that lets you emphasize that is super important. But it does mask the variation in the other places because the outlier has defined the upper bound. So, what I would say is we can always kind of like collect different kinds of insight from the same data by thinking about it in different ways, thinking about things continuously, thinking about things non-linearly, and thinking about things in categorical. So yeah, I love that.
Right, yeah, so just a last.
Good, yeah, tell me.
The relative percentages kind of help to kind of control for that different baseline. And so, yeah, I agree that it's good to show kind of different representations. Maybe you do need to kind of look at the rest of the variation, but it is lost. Like if you were just looking in a bin, say you had a normal distribution and you had everyone in the top bin, you wouldn't see that variation that exists with that bin if you just had them all be the same color. So in general, I think you made a good point about skewed distributions, but in general, when you have a normal distribution, it really can help to show the full detail in that continuous chloropleth.
And just to reiterate what Ashley just said, if you see the two panels to the right, because they're relative change, remember relative change is in contrast to something else. So they do actually incorporate the starting point. So they do like get at both those things, like how much happened in this state as compared to previously. So that's another way of thinking about, you know, absolute measures and relative measures as different ways of tapping into kind of where things are. So I think that's a nice way to pair the two kinds of information. Thank you. Okay, so choropleth maps of something is you know, probably the workhorse of spatial epidemiology, right? This is what we're doing a lot of times is describing the data in this way. We can also do other things. So this one and the next one's a couple examples of using statistical cluster analysis to be able to describe not just where there are highs and lows, but actually to quantify whether there's a statistical hotspot or not. So this is a map of lead poisoning on the left, and then this is a cluster or a heat map of the spatial autocorrelation in lead poisoning on the right in Rhode Island. And here's another example of a project in California where they were interested in women who were eligible for WIC, but were not participating. So in other words, women who could get on WIC, but were not participating. And therefore the question was, is there something that we could do to improve the participation in these places? So they did a cluster analysis of eligible non-participants of WIC and produced this map where there were places where there were much lower than expected and much higher than expected numbers of eligible women who are non-participants. So the idea of using some even somewhat simple statistical analysis to be able to identify patterns is great. And then the last kind of case example, I'm going to use a few slides for. And what I like about this is it's an example of combining conventional epidemiology and spatial epidemiology. So this is a paper by South et al. It was spatial analysis of preterm birth demonstrates opportunities for targeted intervention from several years ago. So their questions were, what factors are driving local patterns of preterm birth in Ohio? And do all places need the same preterm birth prevention efforts? Like if the health department wanted to do an education campaign around things, should it be one size fits all? So they started off by making a map. This is Hamilton County. They used something called kernel density estimation, which is just a means of making this kind of heat map of the prevalence of preterm birth in the county. So you can see based on the legend down here that sort of the average amount was yellow, about 9%. There were places that were lower than average, say as little as 4%, places that were higher than average at 16 or more %. So we can see that there's spatial variation in preterm birth. That's not a surprise. We would see that in lots of places. Now, they took the data and they said, well, what in these data are the risk factors for preterm birth? Or really what they asked is how strongly related are the risk factors? So they used all the data and ran a multivariable regression model, a logistic regression in this case, so it's odds ratios. And here are several risk factors. So things like a short interpregnancy interval or history of a prior preterm birth, or diabetes or chronic hypertension, smoking, et cetera. And you can see that there's a range of risk factors and range of magnitude of association. Now, the question that might happen is you would say to yourself, okay, I'm looking at these, and if I only have resources to kind of develop one education campaign or one intervention, which one of these risk factors should I pick? Should I pick the one that's biggest, or should I pick a different one? It's like, it seems like, you know, like chronic hypertension is not very important, or diabetes doesn't seem very important, right? The magnitude of association isn't very big. So maybe I should drop those. So the question is, how do you sort of pick? Well, their approach was to use something called attributable risk percent, which I kind of feel like, I'm trying to remember, I feel like we talked about this last summer. So this is an epidemiologic parameter. And in its ideal form, and I'll tell you that it's hard to make it actually work in this ideal form, but in its ideal form, what it quantifies is what percent of an outcome could possibly be prevented if we could remove the risk factor altogether from the population. So how much of the actual burden of preterm birth could be addressed if we could control everybody's hypertension or control everybody's diabetes or get everybody to stop smoking? The reason, I just want to give a little caveat, the reason that it doesn't quite work as nicely as said here is it comes down to whether each of these are causally related and how they interact with one another. When we put a bunch of variables in a model, it's possible that, for example, our attributable risk percent could add up to even more than, like that we could prevent more than 100% of the outcome, which is nonsensical. But putting that aside, the idea between attributable risk percent is where's the biggest bang for the buck? And the way to estimate that is to combine two kinds of information, not just the odds ratio that I showed you on this slide here, but also the prevalence of the risk factor, right? So imagine there were two cities, in both cities, smoking tripled the risk of death. But in one city, only 1% of people smoke, and in another city, 20% of people smoke. In both cities, the people who smoked were much more likely to die, but clearly the city who has more smokers, you're going to get a bigger bang for the buck if you were to address smoking. That's the idea. We need both things. We need the magnitude of association and the prevalence. So this is the formula, the prevalence times the, in this case, the odds ratio minus 1 divided by the odds ratio, and it gives us this attributable risk. Okay, why am I telling you all this? What the South paper did was this. They produced that map, and they identified 5 spatial clusters. 3 of them they called hotspots. One of them was a cold spot, like a place where the risk was lower than expected, and one was a warm spot. They did that multivariable logistic regression for the whole data set where they got the odds ratios. And then for every one of those 5 clusters, they created a profile. What's the prevalence of risk factors in each cluster? And then they calculated the attributable risk separately for each cluster. And the result is that, for example, in cluster A over here, which is a hotspot, the driving explanations for high risk were low pre-pregnancy BMI and prior preterm birth. In other words, there was a high prevalence of those two things, and there was a strong enough association. In contrast, hotspot B had a short interpregnancy interval and smoking as the drivers. So there are some limitations about data precision and whether they're actually measuring these things kind of precisely enough to distinguish this, but the idea that we could tailor or understand how one community versus another maybe has slightly different risk profiles. Maybe one community has a lot of immigrants who don't smoke. And so smoking is not the issue in that community, but they still have high preterm birth. Maybe you don't need to have an anti-smoking campaign there. So you need to think about what would be the targeted intervention. So there's some shortcomings with this, but I like this as an example of combining epidemiologic thinking and spatial analysis to produce kind of a new kind of insight. Okay. What is the difference between kernel density and hotspots? Okay, kernel density is a particular statistical analysis. Hotspot map is kind of a trash can word for all kinds of cluster analysis. So for estimating statistical clusters, there's you could use Moran's-I and Lisa statistics of autocorrelation, kernel density, SAT scan. So there's a lot of different tools, and each of them has slightly different assumptions. A lot of times when people say hotspot, like there's no technical definition of a hotspot. It's just a word that says places with higher or lower prevalence or risk. So it's an imprecise word, whereas kernel density is a method. So that's not an entirely satisfying answer, because I just said one is garbage and one is a tool. So, all right. So next steps, we've gone through a lot, and also we're at the end and you're probably ready to go. Obviously, you're not necessarily equipped with all the things that you need to learn, but I want to talk about a few ways you can move forward from here. The first one is, I would encourage all of you to listen to both of these. They don't have anything to do necessarily with epidemiology, but I think they go a long ways in thinking conceptually about what maps and space do. The first one is an episode from This American Life. And it's an interview with a guy who mapped his own neighborhood in many different ways. And it really taps into the idea of maps as filtered reality and as different versions that we can layer of the same place, different ways we can see it. And then this podcast, Shade Equity, How Places Shape Health, it connects social historical processes to urban design to health, including heat-related health outcomes, and how the way many cities are developed promotes or inhibits resilience through shade from trees. So both of these are interesting, I think, and they speak to the idea of, like, what does space mean? In terms of more concretely what you can do, I think you should, if you're interested, you should continue learning and you should identify collaborators. So when I say learn more, I encourage you to learn some GIS software. I'll show you some software options in a minute, but just beginning to learn the tools opens a door to a lot of options, and it gives you something to play with. There's a lot of pitfalls and risks. You need to maybe, do it along with somebody who knows what they're doing, so you don't accidentally, kind of choose the wrong little checkbox or something, but you can begin to learn some GIS software. Learn spatial data visualization and cartography, practice making maps, get feedback on your maps, think about quality of maps. If you're interested, start thinking about learning spatial statistical analysis, like cluster analysis, and always keep practicing, whether you're doing the analysis or not, practicing spatial thinking. What does this mean? Why does this pattern show up on the map? What is the best way to communicate this? Collaborate. So unless you are already a heavy duty GIS analyst, spatial data analyst, you probably need to identify collaborators, right? So you are coming with questions, with data, with an epidemiologist lens, and maybe what you want to do is make some maps of things. So partner with somebody. Many of your departments have GIS analysts. It probably varies across states. So maybe partnering there, you may be able to identify geographers or spatial epidemiologists from other sectors like academia or like urban planners, public planners who may be interested in collaborating on a particular project. So maybe you get the technical skills from somebody else and you bring the epidemiologic insight. In terms of software, I just want to say a word about this because people often ask. ArcGIS is sort of the industry standard. It's a humongous program. It's really expensive. It does tons of things. It's been around for a long time. If you have access to it, great, but it does cost a lot of money. All of these are options that are free. So QGIS is a true GIS program. So it does a lot of the things that ARC does. R does some GIS tasks, but also does data visualization, so cartography, as well as statistical analysis. So you can do a lot in R without having to go to any other program. And then GEODA is a specific utility program that does things like calculate smoothed rates or calculate cluster analysis. It's not really good for making pretty maps. That's not its purpose, but it's good for doing quick analysis. And all three of these are free, so you don't need to spend a lot of money on them. This just summarizes those and a few others in a little bit more detail, and I'm not going to read through these. And here are just some sites for some additional, doing cluster analysis with StatScan or CrimeStat are additional tools. All right, so that's all I've got. That was a lot and also not nearly enough. So tell me what questions you have. Let me get to the bottom of the chat. Did I miss anything? No, I think I got those. Questions, thoughts? All done? All right. Well, not hearing any, here's what I'll do. I'll be happy to stay on for a few more minutes if people do have questions, and I'll also say that I'm done. So Ashley, I don't know if you have other last minute things, but we can make it the end so that if you don't have questions, you're excused.
Thanks, Dr. Kramer. I just have one update. You'll be getting the recording and evaluation from me. So please get that completed as soon as possible while it's fresh in mind. It's helpful for us as we do our final report and plan for the next cohort of trainees that are going through the application process now. So I also want to put a plug in if you received the call for applications for the 2022 course and you have colleagues that are interested or that you would like to share with, please share to continue the next cohort for the intermediate to advanced course. So that's all I have. And thank you again, Dr. Kramer. I don't know if Mike Smith wants to say anything, but thanks everyone for going through a virtual course with us.
Well, I'll just say thank you, everybody. I really appreciate your enthusiasm and your attention as we've spent quite a bit of time together now. You will hear from us again in a few months over the summer. Ashley will follow up with you with just one more evaluation check-in. So, so be on the lookout for that. And just to remind you that you can reach out to us. We'd be happy to talk about analysis issues, epi issues that you're facing in your job. So, yeah, we are available, even though this is the last webinar. It doesn't have to end here. All right. Very good. All right. Thank you so much, everybody. And